muscular structures in this case that we have, yes? So, as we said, we have the part of the superficial, as you can see, posterior axial-appendicular muscles, as well as we do have a part of the deep posterior axial-appendicular muscles. So let's talk about the deep posterior axial-appendicular muscles now, because here we do have a part of a levator scapula, as well as the part of the rhomboids muscle. So what can we say about the part of the levator scapula muscle here is that continuing, where is, yeah, here it is the part of the levator scapula. That's what you can see. From the name, it's already clear what it should be doing. Yes, it should be assisting in the elevation of the scapula. Although it's a small muscle, that's why it will not be a prime elevator. So as a result, here in this case, we do have the descending part, as you remember, of the trapezius muscle, and that's where the part of the levator scapula will be assisting to it in the elevation of the scapula. Now let's see what are the attachment to understand why the action is the elevation. So you can see that the passage of the fibers is approximately the same as it was in the case of trapezius, yes, descending part of it. So you can see that its proximal attachment is mainly associated with the transverse processes of the cervical vertebrae, particularly the first 4 cervical vertebrae. Although on the transverse processes, you remember that we have a part of the posterior tubercle. So this posterior tubercles of the transverse processes of the C1 to C4 are mainly will be the place for the or point for the attachment of the proximal attachment of the levator scapula muscle. In the case of the distal attachment that we have, you can see here that this is particularly the part of, again, the medial border of the scapula, although here you can see that this is the part of the superior portion of it and localized superiorly to the spine of a scapula. You see? So as a result, again and again, as in the case of a levator scapula, the part of the proximal attachment, this is the C1 to C4 transverse processes, and in the case of the distal attachment, simply to say, this is the superior part of the medial border of the scapula. Now, the question is, okay, we do have here this structures. As a result, what it is helping us to do, yes? So, then here comes the idea that it assists the trapezius, as we said, in the part of the elevation of the scapula. And because in this case, imagine that this muscle is contracting, pulling only the superior and medial part of the scapula superiorly, so elevating it. As a result, what will happen? So here you can see, oh, sorry, not here, here. So as a result, imagine that this region is pulled superiorly. So what will happen? You will have the rotatory movement of the scapula too. So in this particular inferior or downward rotation of the scapula will be also assisted by the levator scapula muscle. That's why you can see here back again what we said right now, yes, summarized in this table, that the elevation trapezius descending part is the major, although the levator scapula is important in the assistance, as you can see, as well as we said in the case of the part of the downward rotation. We also have, although the latissimus dorsi is the largest one, that's why it will be the main rotator in this case, but the levator scapula is also assisting in this particular function. Although, to be honest, if you will compare in the real life, like, you know, why do we need this particular movements and how the levator scapula is helping us, in this case, to be honest, when, for example, we are carrying some loads simply, yes. In this case, we do have the stabilization of the scapula again, and it helps us, well, sure, besides the trapezius muscle, because it's still a small muscle, but it helps us to stabilize and fix the part of a scapula, and as a result, we can hold the loads in our hands, you know. So because the whole pressure is distributed from the region of the hands towards the part of the shoulder girdle, yes? And here, particularly the trapezius muscle as well as the levator scapula are helping us to perform this function. So the second representatives of the deep type of the posterior axial-appendicular muscles, these are the rhomboids, as you can see particularly here. They are two. That's why we're most commonly using this word in plural. We do have a part of the rhomboid major, which is more inferiorly localized, and you can see here the part of the rhomboid minor, which is more superiorly localized. So you can see here is that the part of the rhomboid, most commonly, to be honest, it's very difficult to separate them from each other. Okay, it happens like to identify where is minor literally and where is major. Although what we say is that the major is approximately like 2 times wider than the part of the minor. Plus, why we call it rhomboids, it's even more interesting because you know what is rhomboid, yes, shape. So simply, it literally looks like the rhomboid. As a result, we call simply this rhomboid major and the rhomboid minor, this particular muscles. Now, what about the attachments here? And again, as it is the axial-appendicular muscle, sure, we are expecting the attachment, the proximal attachment to the axial skeleton. And in this case, the axial skeleton is particularly the part of the spinous processes of the C7, as well as even sometimes T1-2, and superiorly it's a part of the nuchal ligament, which is helping the to the attachment of the rhomboid minor because it is more superiorly localized in this case. The rhomboid major, as you can see here, is mainly localized inferiorly, and as a result, we do have here directly the continuation of the spinous processes, starting from T2. Extending towards the T5 spinous processes, and as a result, here we do have the whole of this attachment of the rhomboid minor and the major simultaneously. On the other side, or on the distal attachment, I mean, sure, in this case, we do have mainly the median border of the scapula, although this is mainly for the part of the rhomboid major muscle, as you can see. So you can see that the rhomboid major is mainly associated with the medial border of the scapula, that's for sure, even passing towards the inferior angle of the scapula. But in the case of the rhomboid minor, as you can see, it is mainly localized on the superior most part of the medial border, even sometimes attached to the part of the superior angle of the scapula. So as a result, this is how the part of the rhomboids look like. And in this case, imagine that these muscles are simply contracting. So where they will be drawing the scapula? Sure, towards the midline and posteriorly, yes. And this type of the movement, as we already know, we call it the retraction. So as a result, the retraction of the scapula here will be produced by the rhomboids, as you can see, as well as, again, because it's white rhomboids, yes, because their fibers are obliquely directed. As a result, the contraction of them will be pulling the part of the inferior portion of the scapula, yes, and make the rotation again. And this type of the rotation, is again will be the downward rotation. As a result, what we can see particularly here that again, if the in the case, as it was in the case of levator scapula, that's although okay, it's elevating, but it's still not the main elevator. And here we have a trapezius and descending part, and the levator scapula was also contributing in the same and assisting the trapezius muscle in that movement. In the case of retraction, again, the trapezius is a larger one, is much more stronger in the case of retraction. Although, as you can see, the part of the rhomboids are giving them assistance in that movement, as well as you can see the part of the downward rotation. They're also not the prime downward rotators, but they are assisting in that particular movement, you see. So as a result, you can see here that as they are much smaller muscles, I mean both the both the levator scapula as well as the part of the rhomboids, you can see that both of them are trying to fix, let's say like that, the scapula to the part of the thoracic wall, meaning that helping in the stabilization of the scapula to produce the different types of movements. Like, doesn't matter, it will be the movement of the humerus, it will be the flexion, extension, I don't know, rotation, and so on. Okay, so till now, what we were talking for the posterior muscles, we were mainly explaining the part of the superficial as well as the deep posterior axio-appendicular muscles, where we mainly have 4 of them. Yeah. But then we said that according to our classification, we also have the scapulohumeral region or muscles, or simply intrinsic shoulder muscles, which are composed of the 6 different muscles, where we have a part of the deltoid, where we do have a part of the teres major, as well as we do have 4 rotator cuff muscles composed of the supraspinatus, infraspinatus, the part of the teres minor, as well as the subscapularis. So let's see what are these muscles and how they are attached. And here you can see the picture which is designating the attachments of the most of the muscles, except for the part of the deltoid. So here we do have, just a second, somewhere we have here deltoid muscles. First I want to explain the part of deltoid. Maybe here, no, just a second. Yes, here it is. So this is particularly the part of a deltoid muscle. The name of the deltoid is really interesting because if you can see, it is really the inverted Greek. It looks like the inverted Greek letter. This delta is literally like more triangular in shape, you know. So as a result, you can see that it has a very broad proximal attachment, although it's not the literally the, how to say, classical axio-appendicular type of muscles. Yes, because in this case we do not see the in case of the proximal attachment, we do not see the part of the axial skeleton. In this case, it is more, this attachment, it is more looks like as a trapezius attachment, because you can see here that it starts anteriorly from the, or here, let's see this part. So it starts particularly from the lateral region of the clavicle, particularly it's 1/3, lateral 1/3 of the clavicle. Also passes, as you can see here, laterally to the portion of the acromyon, as well as continues to the spine of the scapula. So as a result, it's looks like that surrounds the structures attaching to them, and then covers the part of the shoulder joint or glenohumeral joint, and then attaches to the part of the humerus. And you remember I told you about that region. I told you that mainly on the lateral surface of the humerus we had the projection, which we call deltoid tuberosity. And I told you that when we will see the muscles of the upper limb, that's where particularly we will have the distal attachment of the deltoid muscle. So you can see that it's literally this broad muscle is assembling to make the attachment to the one point of the deltoid tuberosity on the humerus. Now, what is interesting in this case is that simply we can subdivide the whole deltoid into 3 main parts. So as you can see, particularly here, this is the anterior, or also known simply as the clavicular part of the deltoid. Here you can see the middle part of the deltoid, which is mainly associated with the acromyon. And here you can see the part of the posterior portion of the deltoid, or also known as the spinal part of the deltoid. Yes. So what is interesting in this case is that every and each part of it is helping us to perform particular movement. So if you imagine that particularly the middle fibers, middle fibers will be contracting, yes. So mainly because it is crossing the glenohumeral joint, so the movement should be here in the glenohumeral joint, and mainly it is the one which is producing the abduction. So what is interesting is that in reality, deltoid does not initiate the abduction, so it cannot start the abduction, let's say like that. Okay, it needs some assistance, approximately in 15 to 20 degree of the initial abduction, and only after that this middle part of the deltoid can already make the normal abduction of the humerus. So in this case, the assistance is either can be seen in the case of the gravity, when, for example, we are simply laterally flexing the whole body. Yes, so as a result, the gravity will be simply giving us some initial degree of the abduction, or in this case, we have the muscle which is assisting in the very first degree of the abduction, and most commonly this is the supraspinatus muscle. You see, because the supraspinatus muscle, as I said, is associated with the supraspinous fossa of the scapula, overrides or crosses the glenohumeral joint, as you can see particularly here, and is attached to a part of the greater tubercle. So as a result, this first initial type of the abduction is mainly dependent first on the supraspinatus, and only after that the middle part of our deltoid will continue the abduction, and it will make the complete abduction like literally like 180 degrees, but the initial is still dependent on the supraspinatus. Please remember that. Also, what is interesting for us, what about the anterior or part of the clavicula part of it, as well as what about the posterior part of the deltoid, or simply a spinal one? Yes. So in the case of the anterior part, as you can see here, it is helping to the pectoralis major. That's why they show you also here the pectoralis major. It is assisting in the flexion of the arm in the glenohumeral joint, in the shoulder joint. Okay. In the case of the posterior one, it will be vice versa. It will be helping to the latissimus dorsi to make the extension of the arm, so moving it posteriorly. By the way, most commonly when we are walking, normally, naturally, our upper limbs are moving anteriorly and posteriorly, and particularly that movement during the normal walking is mainly dependent on the anterior and posterior parts of the deltoid, respectively. So also interesting part is that because again and again, the type of the joint, in the case of the shoulder or joint one, we have a ball and socket. As a result, the anterior part or clavicular part of the deltoid also will help in some medial rotation. Okay, it will again assist the portion of the pectoralis major in the rotation in this case, and in the case of the spinal or posterior part, it will sure help us in some lateral rotation of the arm, or external rotation, whatever you will call it. So as a result, you can see here that this nice picture 6.31 designates the way how we can examine the patient on the function and the range of motion of the different muscles. So how, in this case, that's what they are doing. They're examining the part of the deltoid. How they do that? So first of all, we remember that the idea of the middle part, let's like that, of the deltoid was the abduction, yes, but from the 15 degrees. So we are asking to move the upper limb approximately 15, 20 degrees. So it start the abduction and then continue it. And here we are applying, as you can see, according to the forces, yes, we are, according to the arrows, we are applying the force by our hands on the upper limb of the patient. Then as a result, if he or she can resist it, yes, and continue and try to continue the movement, so the muscle is appropriately innervated or supplied by the blood and is not damaged. In case if we do have the dropping simply of the upper limb in this case, and simply the adduction is performed, in this case, sure, there is some weakness of the muscle, and as a result, they cannot, I mean, the patients cannot resist the oppositely applied force on the upper limb. Interesting thing is that the same we can say in the case of the trapezius muscle, by the way, in the portion of the trapezius muscle, because it's a large muscle, and you can see that it's the main one in the some movement of the scapula, as well as sure it is stabilizing the scapula. As a result, in the case of the weakness, we can have the literally the drop in the part of a shoulder, you see, and as a result, the movement of the upper limb will be very much limited because of the scapula is not in its normal position. And as a result, even abduction, adduction, I don't know, flexion, extension will be very much limited. So as a result, when we said about the part of the deltoid, yes, which is, as we can see particularly here, helps us in the abduction, we need to say that and to continue to talk about this rotator cuff muscles, because one of them, although it's the part of a rotator cuff muscles group, but it's not mainly rotating anything, as we said, because it is the one which is literally important in the abduction, in the beginning of the abduction. That's why, what do you see particularly here? These are rotator cuff muscles. We can see them here. So the picture A particularly designates the part of the origin and insertion of the rotator cuff muscles, where we do have a part of the supraspinatus attaching here, and the part of the infraspinatus, and the portion of the teres minor. So what is the most interesting part here is that, okay, the distal attachment, the proximal attachment or origin is more or less understandable, yes? But what about the distal attachment? And here comes the idea of the tubercles. As you can see, so this is just easy to remember for us that, first of all, if we talk about the portion of the infraspinatus, as well as the part of the supraspinatus, as you can see here, as well as the part of the teres minor, mainly they are associated with a part of the greater tubercle. And because the greater tubercle is large and contains the different facets, for example, in the case of the supraspinatus, yes, it is mainly the superior surface of the greater tubercle, as you can see here. In the case of the infraspinatus, this is more the medial surface of the greater tubercle, is the attachment or the point of the distal attachment of this particular muscle. In the case of a teres minor, as you can see particularly here, the part of a teres minor is associated with the inferior surface of the greater tubercle. So meaning that they are localized from superior to inferior, okay? So supraspinatus, infraspinatus, and the teres minor on the greater tubercle, they are localized from starting from superior, then the part in the middle, and then in the portion of the inferior surfaces, respectively, sure. But in the part of the subscapularis, which you see particularly here, I do believe it's understandable that it's not associated with the greater tubercle, but it is associated with the lesser tubercle particularly. Now, in the case of the movement, as we said, except for the supraspinatus mainly, all of the others sure are real rotators of the arm. And for example, in the case of part of the infraspinatus, as you can see here, and as it is attached to more medial and sorry, middle part of the greater tubercle, imagine that it is starting to contract. And where it comes from, do not forget, it comes from the posterior region, yes, even posterior surface of the scapula itself. As a result, it will be pulling the part of the humerus where posteriorly, and as a result, we will have what type of movement? We will have the rotation, but this rotation will be external or a lateral type of the rotation. That's what I want you to remember. As well as you can see here the part of the part of the teres minor, approximately the same idea, because you can see here the teres minor, and as a result, because it is mainly attached to the inferior portion or inferior surface, let's say like that, of the greater tubercle, as a result, we can have again the pulling during the contraction of a muscle, the pulling of the arm or of the humerus will be again towards the posterior side, and as a result, we will again have the rotation. Particularly, it will be the lateral type of the rotation. The part of the subscapularis, as you can see here, is mainly attached to the lesser tubercle, yes, of the humerus. And as a result, you can see that because it comes from more anterior surface, as you can see, of the scapula. So as a result, its contraction will be pulling the humerus medially, as you can see, and as a result it will give us, and posteriorly, and as a result it will give us the rotation, but this rotation will be not the external one, but it will be internal rotation, or simply the medial type of the rotation. Okay, so that's what I want you to remember. Again and again, out of 4 rotator cuff muscles, mainly 3 are performing this rotation. All right. So the part of the infraspinatus and the teres minor helping in the rotation, which is external or the lateral one. In the case of the subscapularis, they are helping in the rotation, which is mainly the medial type of the rotation. And in the case of our supraspinatus, we said that it is simply assisting in the initiation of the abduction and assisting it to the deltoid muscle. Till now, was this part clear or not? The last thing, what is literally left for us, this is the part of the teres major muscle, yes? That's what you can see particularly here in a portion of a teres major. Yes, sure, Mohammed, I can repeat it. So do you see where you do have the distal attachment of a part of the subscapularis, yes? So subscapularis is proximally attached to the anterior surface, or correctly to say costal surface of the scapula, okay, and then passing anteriorly from the scapula, it is attached to the portion of the lesser tubercle of the humerus. As a result, when it is contracting, it will be pulling the part of the humerus where medially, yes, towards the median plane, as well as posteriorly. So as a result, because it's the ball and socket joint, that's why it will start to rotate and will be literally rotating towards the portion of the medial side, or simply internally. Just a second, please. Wait for me just 2 minutes. Okay, I'm back here. So, oh, as I said, as a result, we have the part of the medial rotation, you see? So, the last portion, what is left for us to talk here in this case about, this is the part of the, this is the part of a teres major muscle. And what is important in the case of a teres major is that it's not a part of rotator cuff muscles as well as the deltoid, for example, but it is still a portion of the scapulohumeral region. That's what you can see particularly here. That's how it looks like. And as a result, you can see that the attachment, the proximal attachment in this case is mainly the part of the scapula, as you can see, particularly the inferior angle of the scapula. But as it was in the case of, for example, the medial border of the scapula, where we had the anterior and posterior surfaces, yes, here we have the same. So particularly in the case of the teres major, it is localized on the posterior surface at the level of the inferior angle of the scapula. And in the case of its distal attachment, as you can see here, it goes towards the anterior surface of the part of the humerus in the same way as it was in the case of latissimus dorsi. That's why they showed you here the part of latissimus dorsi, although there is the cut, because underneath it we do have a part of a teres major, which is associated with the medial side or medial lip, let's like that, of the intertubercular sulcus. Okay, so and as a result, again, teres major, with a part of its proximal attachment is associated with the inferior angle of the scapula, particularly on its posterior surface. And in the case of its distal attachment, that it is passing the same road as the part of the latissimus dorsi, so moving from the medial side towards the part of the humerus, and here makes the attachment to the part of the intertubercular sulcus, particularly to the medial side of the intertubercular sulcus. Okay, as a result, what could be the movement in this case? And by the way, that's very interesting that both the parts of the latissimus dorsi as well as the part of the teres major, as well as the portion of the anterior extrapendicular muscle, particularly the pectoralis major, all of them together will be producing the adduction, first of all, some part of the adduction. But in the case of the and as a result, because we have here the adduction, and again because it is the glenohumeral joint is again the ball and socket joint, yes, it will be making the rotation again internally. As a result, you can see that the part of the pectoralis major, with the help, with some assistance of the latissimus dorsi and assistance of the teres major, all of them together will be medially rotating the part of the humerus, you see. So as a result, although yes, we've gone through every and each muscle maybe separately, but what is important for me that you could understand what are the movements of that muscles, okay, how they are same or similar. And that's why here in the case of a scapular movements, you can have the very, very good table which helps to simply summarize all of the movements of that region by the different types of muscles, where you can see in the bold, you can see the part of the primary type of the muscle, which is performing mainly this function or action, and all of the others are the ones which are assisting in this particular movement. So as you can see, what we've talked right now about, and the muscles that we've talked right now about, you can see that mainly they are seen in this particular table. Sure, it's just for the part of the scapula, and if they and it's not a part of the humerus, there's additional movements on the humerus, as we have seen, like the medial rotation, lateral rotation, abduction, adduction, okay, flexion, extension. But at least for the scapula, it's a very, very good table to memorize, and I would like to ask you to memorize it because it will be very useful for you and for your midterm. So I do have, for today, I would like to finish with a part of the explanation. Tomorrow at 11, I do believe we have at 11, yes, we have the lecture again, where 1 hour I will be I will dedicate to the part of the axilla and the arm, muscles of the arm, and the second hour I will go through the different types of questions which will be similar to your midterm, okay? So which will be useful for you to go through and to learn. Do you have any questions? Guys, you are welcome, Muhammad. Maybe anyone has. On the midterm, there will be, I do believe, up to 60 questions. That's how I most commonly do. 60 questions.